Dolo or a Combiflam or Ultracet, which is the common thing, I went for my Zolmitriptan right away. Nasal spray, sprayed it in, got rid of it. I was late to the conference, now you know why. It's a problem. A neurologist knows what the adverse effects are. When I sprayed my Zolmist, I was wondering, I was just checking my heart. Is it okay or not? What's happening? I mean, I might have missed some of the risk factors, so where am I going? With today's neurology and today's modern medicine, we don't need to wonder whether something is going to happen with us with the current medicines. We are in for a rich ride, a treasure trove of medicines and devices and therapies, which removes all doubt of risk and gives us a great opportunity to explore the newer options which are very safe. Let's look at them. So, neuropeptides. I bet 10 years back, we wouldn't have heard this term so much when we talked of migraine. Neuropeptides have brought on such a revolution, I can't tell you. 6 years back, not 6, maybe 5 to 6 years back, there was a famous actor who said, I'm not responding to any medication, I want Fremazomenab. So I said, it's not available. He said, here it is. He got it from the US with his own connections. And he had tried multiple medications and both traditional and allopathic, did not respond. And I had only theoretically read about that monoclonal CGRP directed monoclonal antibodies. But having read about it, I gave it to him. To my surprise, because it's all theoretical. I saw him after a week and it gone. He had not gone. The headaches had gone. So the headaches had all disappeared. So that is when I practically realized that this is doing wonders. It's not like the previous triptoma, amitriptyline, propranolol, valproate and all such medications. This was actually doing the work. So then I started believing in CGRP directed antibodies, monoclonal antibodies or CGRP antagonists. We have two main classes which act on the CGRP. CGRP is a very important neuropeptide. It is involved in vasodilatation. It's released from sensory nerve endings into the trigeminal system, and it causes vasodilatation, it causes neuroinflammation and causes pain. So it's one of the most important neuropeptides against which we can direct our treatment opportunities. So we have two classes, monoclonal antibodies and antagonists. Antagonists, we don't have it yet in India. Yesterday was the first session where they introduced it, Rimegepant, yesterday, and we're going to get it. We were just talking at the lunch session about Rimegepant. Somebody was asking me, have you used Rimegepant? I am going to use. I don't want to wonder about vasoconstriction and my heart. I'm going to use it because I know it doesn't cause vasoconstriction and it's going to be pretty useful for treating my headaches. And it's also useful as a preventive. And the thing is, there are other drugs. Let's say you don't have any risk factors. You take the painkillers, the abortive medications continuously. What happens? I can't tell you how many patients I've had of medication overuse headache, where the painkillers themselves are now causing the headaches. And medication overuse headache is very difficult to treat, trust me. It's very difficult, it doesn't go away. So I have to counsel them. My counseling takes 1 hour. I know that I have to cancel some of my OPD on that day. Because simply giving them a medicine and sending them won't work. You have to tell them why they're having the headaches, what is the mechanism of medication overuse. They'll say, I won't believe you. My headache comes down with the Naxdrom. I will take it. I tell him, don't take it. And then we have an argument over that and it goes on. So then I have to counsel them, wash it off with some small course of steroid, and then tell them the benefits of preventive medication. They would have used all of those, it didn't work. Then I have to talk to them about Botox and CGRP monoclonal antibodies. In that scenario, Rimegepant is useful because it does not cause medication overuse headache. It does not cause medication overuse headache. That's one of the gifts. So the CGRP antagonists, they can be used both as prophylaxis and as abortive agents. And the other thing with antibodies is that they start acting quicker than any other prophylaxis. They're very expensive right now. Of course, like all other agents, they're going to be affordable soon, and then we'll have a better time of it. Till then, we'll have a difficult time convincing why the patient has to spend 27,000 every month. But once they do, those who can right now afford it, they're all happy. And we have to offer them the chance, not saying that I'm a conservative doctor. I don't want to stress my patient. Who knows? The patient might want to be stressed and actually relieve his headache. Maybe he can work if his headaches are down, and he can actually use his headache-free days to earn some money. So don't ever deny the chance, the patient the chance to have the best treatment for migraine just because it's expensive. That's about monoclonal antibodies, and there is one more. This is another neuropeptide, pituitary adenylate cyclase activated polypeptide, PACAP. These are the two important neuropeptides which activate the pain in migraine. It also causes neuroinflammation. It also causes vasodilatation. They have a potential role. The antibodies directed against PACAP have a chance to reduce migraines, and those who don't respond to CGRP directed drugs may respond to this. So far, till the Arenumab came widely available in India, my favorite was botulinum toxin, just because of the safety profile and the efficacy. It is as effective as topiramate I haven't seen any side effects so far. And if somebody can afford it, this is the one I recommend to them very commonly. Now, what is the alternative to triptan still now, till rimegepant comes in? Lasmiditan. Lasmiditan does not cause vasoconstriction. But please don't give before the patient drives, because it can cause severe dizziness and drowsiness. They can have accidents. Don't give this before they drive. And they should not drive for 12 hours after they take lasmiditan. 8 to 12 hours. I would prefer 12 hours. Now, what are the drug-free options? Patients say, I don't want to take medication. Especially when they're pregnant. You can't give them medication. So what do? The patient is planning pregnancy, or the patient is pregnant. They cannot take medication. There are some patients who are not, but they don't want medication. So there are various neuromodulation devices which act on the pain pathways. They can act on the pain pathways, the TCC, and such areas, and modulate the pain. What are they? Nerivio is the one which is most commonly used. It's the brand name for the remote electrical neuromodulation device which is being promoted by Dr. Reddy's. It's worn on the arm, and it is stimulated. There is a electrical stimulation. It stimulates the upper limb nerves, and these nerves, once they in the pathway, they inhibit the pain fibers by modulating the periaqueductal gray and the rostral ventromedial medulla. So there the serotonin and norepinephrine are modulated to control the pain. The migraine pain is reduced because of this. Has anyone used it? Nerivio? Anybody? Not yourself. I've used it myself. It is very modestly effective. It's not as effective as the other anti-migraine drugs. So it can be used both as a treatment and a preventive. But for pregnant women, it's a safe option. For others, although the company promotes it as a sole prophylactic, I would still recommend it only as an add-on because of its modest efficacy. But it works. Sometimes when the headache is not very severe, people are better off using it rather than medication when they don't want medication overuse headache. It works, but you should take it early. If you delay the application of Nerivio, it's not very effective. Now, transcranial magnetic stimulation is being used for multiple conditions, especially in psychiatric conditions, OCD, depression, severe depression, then anxiety. All of these conditions respond very well to RTMS, repetitive TMS. But for migraine treatment, acute treatment of migraine, single pulse TMS, it's a portable device. Unlike the repetitive TMS where it's a large machine, you can't carry it. But single pulse TMS, it's a home device. In the US, it's used as a subscription device where they can carry it home, but it costs $295 or $395 per month as a subscription fee. But the people suffer so much from migraine, they don't mind paying that fee. So single pulse TMS. You apply a single pulse, it stops the cortical spreading depression and the headache is aborted immediately. No medication needed. So that's a gift for people who don't want to use medication. But some people have said that repetitive TMS may help prevent migraine attacks. So when I spoke with one of the people who deal with RTMS, they said that there are some magnetic parameters, there are some parameters which can be modified to treat acute attacks also in RTMS. Have anyone used RTMS here? TMS. So it's becoming quite popular and it's available at multiple places now. Mostly psychiatric centers have it, but the neurologists have also started using it because it can help in neuro rehab also. Aphasia, motor power, all these things can be improved with TMS, repetitive TMS, along with migraine of course. Then you have Kefali. Kefali is a band-like device which is worn on the forehead where by transcutaneous electrical stimulation, by stimulating the trigeminal nerve, it reduces migraine. Again, like it's slightly less efficacious than even Nerevio. So this has not taken off and it is quite expensive. The electrodes you have to buy. So it's not very simple. It's the cost and the efficacy don't go hand in hand compared to other drugs. So I stopped using it. I used it for a while. For 6 to 12 months I used it. Not for myself, for my patients. For me it never worked. For my patients, they were also not happy. So stopped using it. But maybe in combination with other things, it might still help. Vagus nerve stimulation. Neurologists know for epilepsy it's quite useful. It's also useful for headaches. It is a non-invasive vagal nerve stimulation for acute therapy. So they stimulate the vagus nerve from outside and through modification of pain pathways, it reduces the incidence of migraines. It can be used both as treatment and as prophylaxis. We all know greater occipital nerve blocks. They can be used to treat migraines and sometimes they can be used to treat cluster headaches. But implanting electrodes to chronically stimulate the occipital nerves is one method where the migraine episodes can be brought down significantly. Then there is a caloric vestibular stimulation device where it's like worn like a headphone with conical projections which go into the ear. They stimulate and cause reduction of headaches. This is a very simple thing. It's a green lamp. There is something called narrow band green light, 520 nanometers plus minus 10. In that band, green light can actually decrease headaches. You know that red and blue, in that band, they can worsen headaches. Blue light can worsen headaches. That's why people ask you not to use a lot of screens because the blue light can worsen your headaches. When people watch a lot of screens just before sleeping, they wake up with a severe headache. But green lamps, when you sleep with a green lamp or use a room with a green lamp, especially in acute situations, it can bring down your headache significantly. So these are commercially available. You can order it on Amazon also. So this is one thing which can help because along with quieting the room, if you just have a green lamp, they're better off. Then there are orexin receptor antagonists like DORAs. But we have DORAs. We don't have... Now there is a difference between orexin receptor 1 and orexin receptor 2. If you target orexin receptor 1, it reduces the headaches. But targeting the second receptor, type 2, may worsen it. So you have to balance there. Now DORAs involve both the receptors. So they're not yet useful. You know the DORAs? Lemborexant. Suvorexant is also there, but lemborexant is the one Dayvigo. It's known as Dayvigo. But it hasn't shown promise in headaches because it stimulates, it's an antagonist to both receptors, DORA. Then you have the TRPM8 channels. When some people have headaches, they apply coal to the forehead. They apply ice to the forehead or apply menthol. It works because these receptors, these channels get activated. Now they're trying to find out medications which can alter or modify these channels. Then nitric oxide system. When cardiac patients come to you, they're on nitroglycerin. It worsens the headaches. They receive nitroglycerin, they have headaches. That because nitric oxide system is very sensitive, causes vasodilation, neuroinflammation, headaches. When you can modify this, you can control the onset or control of headaches. Adenosine receptors. Why does coffee relieve headaches? Does anyone have migraines here? Anyone? Very few. I'm surprised. The consensus is that most neurologists have migraines. If you're not raising your hand, I have to. So, has anyone had the experience that coffee relieves headache? Anyone? For me, yes. But it is also true that when you take more than 3-4 cups of coffee, it can cause headaches. Have you had that experience? So, coffee has a very dicey relationship with headache. That's because adenosine. So, when you wake up, when you get up from sleep, your adenosine buildup is nearly zero. As the day progresses, your adenosine builds up. You have a sufficient level of adenosine. That is what causes you to go back to sleep in the night. Coffee binds to the adenosine receptors. That's why coffee keeps you awake. Some of the people who take coffee may not sleep. They have a different way the receptors act. But coffee and adenosine go together. Adenosine is being explored as a potential target for developing migraine therapies. And neuropeptide Y analogs are also being probed. Now, we all know migraine is a genetic disease. So, why not target the genes? It's not easy, but various things are being tried, like CRISPR therapy or gene delivery systems which can deliver the genes directly to the relevant brain regions so that we have a long-lasting therapeutic neuropeptide modulation. Viral vectors, stem cell applications, all these things are being probed to target migraine. And now, what about using nanotechnology to deliver the drugs directly by crossing the blood-brain barrier? Because blood-brain barrier blocks many of the molecules from reaching adequately. So you can use smaller doses and target the area carefully so that the efficacy of the drugs is higher. Now, there is something called magic mushrooms. Magic mushrooms. They're called shrooms. Now, psilocybin is the active component of this magic mushrooms, which causes hallucinations. So, there is an area which is called default mode network in the brain, which causes you to have self-awareness. Prefrontal cortex, amygdala, these are the areas which make you look inward. Self-awareness. You're always thinking of yourself. Let's say you're in a situation. You're not able to connect to the outside world because you're thinking of yourself more. That is what the default mode network does. This default mode network doesn't let us enjoy things. It doesn't let us connect. We are so inward thinking that we are not even connecting to what's going on around us. Have you had this experience? That we are inward thinking. We are thinking about ourselves. We are thinking how we come off when we meet others. We are thinking what is going to happen to us. When somebody tells about their achievement, we are thinking, why am I not achieving this? Why am I in this place still? How am I lesser than that person? How am I better than that person? All these things are promoted by your default mode network. Imagine if it goes away. That's what this does. You start connecting to the outside world. So what is the consequence? You connect so quickly that there are lots of other feelings you experience. Some of them may seem like hallucinations. Some of the experiences are otherworldly. That's what happens with psilocybin. People outside can get psilocybin. India, it's illegal now. But I think with the therapeutic potential of psilocybin, it's not going to be for long. Now, if psilocybin is taken in certain quantity, you get hallucinations, you connect with the outside world, you feel, I don't know what the yogis or other people in the Himalayas use, but they seem to be connecting very well to the other worlds. We can too. I'm not recommending it. I'll be caught and put in jail if I do this. I don't want to be. But when we use it in lesser quantities, we can modify the networks. Imagine the potential. Neurodegenerative disorders, dementias, many of these things can be rewired if this is modified. Of course, people thought of cannabis like that. We use CBD now for our epilepsy patients. So it's not far off. The day is not far off when people will modify this and will be using regularly. Another couple of years' time, think of this talk and you'll say that, okay, psilocybin, now we know. So it is going to come into practice. In a lesser dose, it can prevent a lot of neurodegenerative disorders causing rewiring. Because when you're people are very disciplined, do the same thing every day, versus people who do different things every day. Indisciplined, different things, again, not a recommendation. So when they do that, who do you think is going to develop their brain more? People who do different things, because they need those connections. You're forming different connections. Your brain is trying to be plastic and you're trying to be disciplined. So this one makes you indisciplined. But if you do it in a disciplined way, you're better off. It also prevents migraines and treats them. So psilocybin. So in the past, when, let's say, a patient had severe migraines, chronic migraine, more than 15 days a month, you gave amitriptyline, propanolol, valproate, topiramate, nothing worked. And patient came to the doctor and said, what's happening? Doctor said, just deal with it. Like this person in the painting Scream, done by Edvard Munch, Norwegian artist, wonderful one. But I'm sure he experienced either migraine or some other torture like that. Look at this painting. So now you don't have to do it anymore. There are wonderful options available. Very few side effects, little expensive. But as they catch on, I'm sure they'll become affordable enough so that more of us can use it and can be pain-free. Thank you.
Thank you for an engaging and thought-provoking session, sir. I request Dr. Kumarvelu sir to come forward as we have a small momentum as a token of appreciation to Dr. Srikanth sir, and I request all the panelists to join.